Okay, so welcome everybody. My name is Jonathan Lovegrove. I'm one of the PMH EMS education officers for the region, and what I'd like to do is take a few minutes out of your time to go through the newly released OMD Care Map, Acute Coronary Syndrome. So let's take a look and see what's new. First thing we've got is we have a newly released streamlined care map from OMD, which is really nice, and we're going to take a look at that in a minute. Next big ticket item we should talk about is the fact that PCPs are now going to be able to administer intranasal fentanyl when patients have ACS type symptoms. So that's a really good addition. As well, I'm going to share with you some updated dosing guidelines for ASA. The next thing we're going to look at here is the change in systolic blood pressures in terms of nitroglycerin administration. So we'll go through that. And then the last thing we're going to talk about briefly here is we're going to talk about fluid bolus for these patients that are hypotensive, either because they are hypotensive with ACS or because we made them hypotensive. So let's take a look at the care map. We're going to take a look at document E04.1A, Acute Coronary Syndrome. So this is the new revised document that OMD has released, and we're going to go through it piece by piece here. So I've blocked out most of it just so we can focus on the areas that we're talking about. So number one, we start with oxygenation for these patients, and our target SpO2 goal for these patients is around 90%. So if they're short of breath, then absolutely go ahead and provide them with some oxygen. But if they're not complaining of any shortness of breath, then our target goal is around 90%. As you can see, there is there's a range now that you can dose for your ASA from 160 to 325. And basically, I would say that you are more than okay to just continue dosing at 160. This would be more appropriate for sites or regions maybe that only stocked a 325 milligram dose of ASA. So for us, 160, it works absolutely fine. The other thing that's changed on this now is the fact that if the patient has taken ASA in the last 24 hours and you can verify that, then you don't need to repeat it. What I would caution is that most people that take a daily dose of ASA probably only take about one baby aspirin per day is the regular dose. So most likely you would need to top them up, or you could just repeat the entire 160 dose, and that would be fine too. So they've got 12 leads right at the top of the algorithm here. That's a great idea. The thought behind that is that if you do a 12 lead, you're looking for a STEMI. You wrap the precordial leads around to get a 15 lead. So you're looking at the V4R lead as well as V8, V9 for the posterior. If you do notice at the ICP level that there is elevation of more than 1 millimeter or one little box on your charting paper, then that would indicate that there is a right ventricular infarct, in which case you need to withhold your nitrate therapies and, for the ICPs, morphine. And we know for a fact that not every site has a 12-lead capable device, and that's understandable. So if you don't have it, then you don't need to worry about it. But if you do have the device, the expectation overall is that within 10 minutes of initial patient contact, that you'll put that 12-lead on the patient. And it's a good idea as you're going through as well, just because the 12 lead is just kind of a snapshot in time, to kind of get a serial EKG. So get one before you give your nitro if you can, get one after, just kind of, you can do them throughout the entire progression of the call just to see how things change. And even if you can't read it or understand it, that's totally okay, because you can pass that and forward that on to the doctor when you get there. So the next part here is the code STEMI bypass. That's not a part of the protocol that we have to worry about, and that's simply due to geography. We're more than 120 minutes away from Winnipeg facilities that are running this protocol, and as a result, we're not in a position to be able to do a STEMI bypass as of yet. So then we get down to administer sublingual nitroglycerin. So EMRs or MTECs, you're not able to administer nitro patches, but you are able to use the spray. And you can use the spray right out of the bag as long as you're following the indications and the contraindications. And it's not clearly written in here, but generally accepted guidelines and standards say that you give 3 doses of nitro, and then after 3 doses of nitro, if the patient is still uncomfortable and experiencing pain, that you would move to an opioid. So in this case, at the PCP level, you now have the option to move over into intranasal fentanyl. The only reason why you wouldn't follow that pathway would possibly be that you give nitro and then you have a precipitous drop in blood pressure, in which case probably more nitro would not be a good idea. And we'll talk about that more in a second. The other thing that changes is the systolic bottom pressure for administering nitro. It goes down to 90 millimeters systolic. So there's a bit of a change, and I'll review that again on the med page as well. So then we're thinking about getting vascular access. So depending on the patient's blood pressure and perfusion, you may need to consider infusing. It's just going to be patient dependent. The topical nitroglycerin, we see that as being really, it's not going to be a frontline thing that we really push for all patients. We see this as more of a maintenance issue. So perhaps you've administered your 3 sprays of nitros and maybe you've already given a dose or 2 of fentanyl. The pain is down to 0. However, maybe after 5 or 10 minutes later, the patient's saying, oh, you know what, I've got pain, it's starting to come back a little bit. It's maybe 1 or 2 out of 10. We think that that would be a really good place for the topical nitro to be administered then. So just kind of a maintenance, just giving that steady, slow release of the patch. The other thing to keep in mind is the patches, the absorption patterns are going to vary from patient to patient. So it depends, are they hairy? Is there a lot of body mass? How vascular are they? So there's, or is there dirt underneath the patch there that So just think that there's a lot of variabilities in terms of the absorption. So not everybody's going to get the same level each and every time. So just something to keep in mind. So again, the patch, we're saying it's kind of optional on this. And then we keep moving down here. So has the pain been relieved by the nitro? And like we talked about, you can do about 3 nitro doses sublingually, and then you move over into an opioid. So ICPs, if you're listening to this presentation, nothing changes for you folks. You can still administer either the morphine or the fentanyl by all available routes. However, at the PCP route, this is exciting for you, and the fact that you are now going to be able to administer intranasal fentanyl to these patients. So just know that intranasal fentanyl, that there are some drawbacks to administering this route. It's not as an effective route when you give it intranasally versus intravenously. So if the option is there to have an ICP administer it intravenously, that is the superior option each and every time. The onset of action when fentanyl is given intravenous is immediate, whereas the onset of action when you give it intranasal is 5 to 10 minutes. And that's only if you give this spray absolutely perfectly and aerosolize it and everything, and it all works. So it can be less effective for sure. There's a little note here: if hypotension develops, discontinue nitro, remove any topical patches that you've put on the patient, and administer some fluid. So maybe fluid in this case, but maybe just a small amount. So instead of just going 20 mLs per kg to a max of a liter for adult, maybe give 5 to 10 mLs per kg. Just do a smaller bolus. Really keep track of these patients. They're already having some cardiac related issues, so you don't want to overstress and strain the heart. So this is the nitro page here, so M21A. What I will let you know is that OMD has not corrected their medication page for nitro, even though you can kind of see, probably your eyes are drawn to it like mine. There's a red line through the systolic blood pressure less than 100. It's now 90. And so that's just to let you know that OMD has said it's okay in the ACS setting to administer nitroglycerin for pressures all the way down to 90. So by extension, that should mean that we are now going to be able to administer nitro to hypertensive emergencies. as well as for acute heart failure down to 90 systolic. But remember, OMD is not changing the medication page, so you're going to have to remember that the pressure is changed to 90. That's all I really wanted to point out on this. Everything else stays the same. And this is a memo. This is just kind of a copy paste from a memo that we put out. So the top portion here, it basically is a cut and paste from the OMD protocol for the acute coronary syndrome. And what it is essentially saying is if you have a drop of 30 points systolic from your initial after you begin treating an ACS patient, that you are to stop immediately. So for us, we're having a little bit of issue with that. So basically, if you think this through, maybe you have a patient that has ACS related symptoms, they're pale, cool, diaphoretic, they have a blood pressure of 180 on 110, you give them 2 shots of nitro, and now after the second dose of nitro, their blood pressure is sitting at 150 on 90. They're still complaining of 5 of 10 pain. However, according to the information that's in the OMD Care Map, at this point, that would mean that you are no longer able to treat this patient with either nitro or opioids. We're going to supersede that part of the document and we're going to alter it. And what we're going to say, and it's in the tips down here in the bottom here, so if the systolic blood pressure drops below 90 millimeters mercury at any point, nitro is now contraindicated. And like we talked about on the previous page or two, we said if the blood pressure becomes hypotensive, consider small fluid boluses. And then once that issue is resolved, you're not going to go back to the nitro because it's going to drop it too quickly. Fentanyl would be a better option for you. Whether you're an ICP or a PCP, fentanyl just doesn't cause those significant drops in blood pressure and therefore would be a better option. The last point that I'm going to talk about here, so if you expect or think that nitro is going to potentially lower the patient's systolic blood pressure below 90 with another dose, so maybe the first drop went down by 25 or 30 points and now you're sitting at 110 systolic and the next dose is probably going to bring them down under 90, then it's reasonable to not administer that nitro again. So it may be that you only administered 1 nitro and then you switch to an opiate, and that's just because you don't want the patient to become hypotensive, and that's all right if that's your decision. And we're going to look here at M37.1, so this is the ASA. The only thing that changes on this entire document, and the only thing I'm going to talk about, is the dose, and that's the 160 to 325. I'm going to say that overall it's still probably in the patient's, it's either the 325 or the 160 works equally well. So because we have 80 milligram tablets, the direction that we are giving is that it's probably better if you just give them 160. There's really no stronger rationale to give them 325. It's not going to work better or anything like that. It's just more for jurisdictions that maybe only stock that 325 pill, or for patients that take it at home. That's okay. So if they've taken it and you know that they've taken ASA before you get there within the last 24 hours, then you don't need to repeat. But like I said earlier, keep in mind the daily dose of ASA at home is generally about 80 milligrams or 81 milligrams. So you can either top it up or just administer 160. Okay, so let's take a look at our nitroglycerin dosing here. I just want to review this, and I do want to point out pretty clearly here, just to let you know that the medication page has not been changed to reflect the changes in the care map, which now allow you to administer nitro down to 90 millimeters systolic pressures. So just be aware of that. So it is okay to administer nitro right down to 90, okay? The med page is not going to reflect it. Sublingual dose 0.4 milligrams every 5 minutes until the pain gets to 0, or until you've tried it about 3 times and then you move on perhaps to an opiate. Topical dosing, it goes by systolic blood pressures. So 100 to 150 is 0.2 milligrams a patch. 150 to 200, they get 2 patches equaling 0.4 milligrams. And if their pressures are greater than 200 millimeters mercury, they get 0.6 milligrams per hour. So just remember, keep in mind at least that nitro affects everyone a little bit different, at least in terms of the nitro patch. The absorption pattern from one person to the next is going to be a little bit different. However you give it, just keep in mind that it's a really slow release type administration. I just want to quickly review intranasal fentanyl dosing with you here. So ICPs, don't get alarmed. I didn't include morphine here. You're still okay to give it, and as well, ICPs can still administer fentanyl via any route that they choose. The reason why I've got adult only listed here for fentanyl is simply because the ACS algorithm only allows you to administer fentanyl or treat those patients if they're an adult, so greater than 17 years and older. So common sense, makes sense. Just remember that anytime you're giving an intranasal administration, no matter what the drug is, it's given in an undiluted format. So key to remember there, just draw up what you need from the ampule and administer that. Whatever remains in that glass ampule, you still need to put it somewhere secure. So it's not okay just rolling around in a broken glass ampule or taped to the side of the truck or something like that. You need to draw up whatever remains in your ampule into a syringe, label it, and then cap it. That's best practice. That's it, everybody. We've made it to the end here. So if you're listening to this now, we can almost guarantee that we've already gone live with this protocol. The implementation date is December 1st of 2018. Just a reminder, if you haven't already done so, click that you've read the memo once you've read the memo and or once you've viewed this and you're comfortable. If you're not comfortable and you have any questions, as always, please contact one of the EMS education officers and we would be more than happy to be able to help you with whatever questions you have. Okay, thanks everyone again, and hopefully you found this useful and informative.